This meeting will be recorded, so for on-demand access. And I'll go ahead and share my screen and welcome everybody. It's very exciting. We're starting the new year of the, or the new academic year, I should say, of the JVS Journal Club. So give me just 1 second. There we go. So thank you and welcome. It is July, the beginning of the academic year. As we were talking about, some people took their boards today, always an exciting time. And we're starting with 2 really exceptional manuscript articles that were in the July episode or July version of the JVS. Today will be hosted by the University of Rochester and Oregon Health Science Center, both divisions of vascular surgery. And we'll be talking about prophylactic sac outflow vessel embolization is associated with improved sac regression in patients undergoing endovascular aortic aneurysm repair, and also failure to preserve the internal iliac artery during abdominal aortic aneurysm repair is associated with with mortality and ischemic complications. The University of Rochester Medical Center joining us as the faculty introducer is Dr. Grayson Pritchard. He is an assistant professor of surgery, and also Dr. Leanne Grafmuller, who attended her first VAM this past June to present. It was very exciting, her poster. She's an integrated vascular resident there. From OHSU, Dr. Amani Politano, who has been lucky enough to join us once before on this venue, and then their first year vascular fellow, who's also joining us. Excited to have him with us as well. Let's see. In terms of author guests, from Dr. Karan Garg from the Division of Vascular Surgery at New York University, and also the Chief of Vascular Surgery at the Manhattan VA, as well as a couple of his other colleagues may be joining us to discuss their paper and field any questions. And Dr. Chung Lee was going to join us from South Korea, but unfortunately he just started an emergency case and will not be able to be with us. So we'll rely on our presenters and also the moderator, as well as the audience, to really discuss this paper together. We have 2 special guests that will be moderating with us. From the JVS, Dr. Gail Tang. She is an associate professor of surgery at the VA Puget Sound Health Science Center, or Health Center at the University of Washington, and also Dr. Ravi Rajani, who is the assistant dean for medical education and at Emory University. Just a few little housekeeping notes. Please stay muted. Put your comments and questions in the chat. The discussion leader may call on you to speak, but we'll also address each of those. As we mentioned, the event is being recorded for on-demand access. And then for August, Stony Brook and the University of Alabama will be hosting on August 11th. And we're finalizing the dates for September through December, as well as the moderators. So you'll be getting more information about those. So I will stop sharing my screen and we will turn it over so that we can get started with our first paper.
Thank you, Dr. Humphreys and Dr. Muzio for the opportunity to discuss this relevant paper. We're excited from the University of Rochester to be here. My name is Grayson Pitcher. I'm an assistant professor there, and our excellent third-year resident who you've already introduced, Dr. Leanne Grafmuller, will be presenting the prophylactic sac outflow vessel embolization articles by Drs. Rakosh and Garg. I think this is a really relevant topic. It was a conversation piece for the failing EVAR session at the vascular annual meeting this year. And there's even a few trials on the horizon with some new technology from prophylactic sac remodeling. Before I want to discuss the topic of EMBO-EVAR, I want to back up and just introduce the concept of endoleaks for our medical students joining us tonight. This is an image of an infrarenal abdominal aortic aneurysm. Below the renal arteries, there are multiple vessels that arise directly from the aorta. One of these arteries is the inferior mesenteric artery, or IMA. Now, we know the mesenteric circulation has a robust collateral network. In this image, we see a depiction of the collateral network between the SMA and IMA. And the IMA is not the only artery that arises from the aorta. We have lumbar arteries, accessory renal arteries, and middle sacral. When aneurysms are repaired endovascularly, we exclude the blood flow to the aneurysm sac. In the majority of the patients, this results in cessation of blood flow to these arteries. However, in roughly 20% of patients, blood flow is still maintained into the aneurysm sac from these small vessels by collateral networks. The long-term significance of this has been the topic of debate for years. The good news is we know that 80% of type 2 endoleaks resolve by 6 months, and these are not associated with adverse outcomes. However, it's the type 2 endoleaks that don't resolve that we don't have a definitive answer to yet. So the question remains, does persistent blood flow to the aneurysm sac increase the risk of aortic remodeling and aneurysm growth? This was in 2007, Dr. Cambry and the groups from Mass Gen published really a landmark paper for their concerning findings of type 2 endoleaks. Again, this is from 2007. They found that persistent type 2 endoleaks were associated with late endograft failure, increased reintervention rates, and secondary rupture. So really, as a result of this paper and a couple other smaller studies, the Society for Vascular Surgery put out their guidelines for recommendation of treatment of type 2 endoleaks. Their recommendation was when the aneurysm sac grows 5 millimeters or greater in size. Correspondingly, European guidelines also changed as well at that time to include greater than 10 millimeters in size for treatment. And as vascular surgeons, we came up with a whole host and variety of approaches to treat these endoleaks. This started with transarterial approaches, directing a catheter from the SMA to the IMA and putting coils, glue, plugs into the aneurysm sac to fill the space, or specifically targeting the IMA, accessory renal arteries, or lumbar arteries. And then instead of coming from the arterial system, we even came from the IVC, punctured the IVC, and punctured the aneurysm sac. And finally, we thought, hey, why don't we stick a needle through the patient's back directly into the aneurysm sac and fill it with everything we have? And so those have been the approaches that we've all taken throughout the years, just to name some brief ones. But the problem is, despite all these techniques, we've only achieved modest clinical success. And what we found is that there's a high rate of recurrence of these type 2 endoleaks despite all of this treatment. Now, this is a CT scan we're all too familiar with after coil embolization. I must be a really good vascular surgeon because I can't see any evidence now of a type 2 endoleak, right? Or maybe it's just because there's a whole bunch of artifact in the way, and the aneurysm's really been growing 2 centimeters in size for the last year. And so that's sort of where we're stuck. And now there are a lot of considerations with treatment of type 2 endoleaks. These procedures are often hard. There's a higher degree of difficulty to direct a catheter from the SMA through the collateral networks of the IMA, or even with translumbar embolization, there's a high degree of learning curve with that. You can't just easily come from the arterial system without putting a hole in the graft, and all these interventions and re-interventions that we do for the patients add a ton of cost. So why don't we embolize the IMA, accessory renal arteries, or lumbar arteries when we perform EVAR? We can leave a sheath within the aneurysm sac, deploy the main body, and stuff a bunch of coils, glue, or whatever we have that's on the horizon with a couple of these interesting trials into the aneurysm sac and even the branches. And that's exactly what EMBO-EVAR is. It's prophylactic embolization of the sac outflow vessels in the aneurysm sac to prevent type 2 endoleaks. However, the available evidence is largely limited to date to small single center retrospective studies with a predominant focus really on actually IMA embolization more so than sac filling or literature on accessory renal arteries. So with that, I'd like to introduce Dr. Iliac Grafmuller to present this paper on EMBO-EVAR and prophylactic sac embolization, which is really the first paper of its type within JVS. That's not a single center retrospective study.
All right, thank you, Dr. Pitcher, for the introduction, and thank you to the Journal Club organizers for the opportunity to present today. This manuscript comes from our colleagues at NYU, Columbia University, New York Medical College, BID, and the University of Chicago. As Dr. Pitcher mentioned, there have been small retrospective studies that have shown decreased sac growth and incidence of type 2 endoleak with prophylactic outflow vessel embolization. The authors of this study hope to expand that research on a larger population. So to that end, they assess the effect of prophylactic outflow vessel embolization during EVAR on aneurysm sac characteristics. This was a retrospective study of prospectively collected data where the authors queried the endovascular AAA VQI module from 2009 to 2020. Of the 56,000 EVARs performed, exclusion criteria eliminated patients that had undergone prior aortic repair, were less than 18 years of age, and patients that underwent emergent or urgent intervention for symptoms or rupture. Additionally, patients that did not have follow-up imaging data or had data points missing that were clinically relevant to the author's clinical question were excluded. Of the remaining 15,000 patients, 272 had a prophylactic outflow vessel embolization, and the rest underwent EVAR alone. The primary outcome of this study was the rate of aneurysmal sac regression. Sac regression was defined as a decrease in aneurysm sac size greater than or equal to 5 millimeters. The secondary outcomes studied were in-hospital post-op complications, the incidence of type 2 endoleak, and reintervention rate. The authors used the following statistical methods for their data analysis. Their first table reports patient characteristics, and when stratified into two study populations, those undergoing EMBO-EVAR or EVAR alone had similar reported ages, race and ethnicity, comorbid medical conditions, and preoperative medications. Notably, there was a higher percentage of males in the EMBO-EVAR group that was statistically significant. Additionally, aneurysm sac diameter did not differ between the two study groups. When examining procedural characteristics, as expected, patients undergoing EMBO-EVAR, i.e. 2 procedures, had longer total procedure times, fluoroscopy times, had higher doses of contrast, and received more IV fluid. They did not have greater EBL or higher transfusion requirements. Composite and stratified intraoperative complications did not differ between the two groups. Lastly, they discovered that the most commonly embolized vessel was the IMA, followed by accessory renal arteries, then lumbars, and 4.4% of patients had 2 or more vessels embolized. Table 3 reports one of their secondary outcomes, endoleak incidence. It shows that at case conclusion, there was no difference in the rate of any endoleak type, regardless of whether they received a prophylactic outflow vessel embolization or not. Even when type 2 endoleaks were stratified by culprit vessel, there was no statistical difference. There was, however, a higher rate of indeterminate endoleak between the EVAR only group, likely due to differences in study population sample size. When several common postoperative complications and hospital quality metrics were examined, the authors found no difference in those receiving prophylactic vessel embolization or EVAR alone. In their most interesting table, we learn that patients had a mean follow-up of 14 months, and those receiving EMBO-EVAR had smaller maximum aortic diameters and saw a greater decrease in aortic diameter during the follow-up period, which is great. But with respect to their primary endpoint, rate of sac regression, there was no association between sac regression, stability or growth, and prophylactic embolization. Additionally, EMBO-EVAR did not result in lower rates of type 2 endoleak from any vessel. reintervention, or the composite endpoint of mortality reintervention. One important detail that the authors probably couldn't tease out from the VQI dataset is that if the embolization of the vessel worked, i.e., did the vessel that was embolized cause a type 2 endoleak in the future or not? Table 6 depicts the results of their multivariate logistic regression. It shows that prophylactic embolization prior to EVAR was an independent predictor of SAC regression. Conversely, older age, the presence of endoleaks at follow-up, and postoperative anticoagulant or antiplatelet therapy was associated with an increased risk of a stable or growing aneurysm. Given the large imbalance in study population size, it makes sense that the authors performed a propensity matching. However, this didn't show anything inconsistent with what we've already talked about, so we'll skip over that. We all know the limitations of retrospective studies and the VQI, but in direct reference to this study, I think knowing details like number and diameter of vessels embolized, as well as endograph model, are all worthy of subcategory analysis. Albeit one could argue it doesn't matter since the EMBO-EVAR sample size was so small and statistical significance is unlikely. Additionally, the disparity between sample size in EVAR only and EMBO-EVAR study populations could have decreased the study power, and therefore the morbidity associated with EMBO-EVAR might not have been actually accurately captured here. Although EMBO-EVAR did not prevent endoleaks from occurring intraoperatively, it was associated with a smaller post-op maximum aortic diameter and a greater decrease in aortic diameter during the follow-up period of 14 months. Regarding the study's primary outcome, there was no statistically significant difference in SAC regression. However, although the measure of greater than 5 millimeters was probably based in the literature, it in the end is probably an arbitrary value, and we don't know the quality of it as a marker. As far as secondary outcomes, EMBO-EVAR did demonstrate acceptable morbidity and mortality. There's always more work to be done, and I do think there is a valid role for identifying subsets of patients or aneurysm characteristics that would derive the most benefit from a prophylactic embolization. And with that, I'll open the floor to discussion.
Thank you, Dr. Grafmuller. Dr. Rajani is going to open up the discussion and address some of the questions to the authors for us.
Yeah, thanks everybody. Thanks, Dr. Grafmuller. Thanks, Dr. Pitcher. Great job presenting this article. I'd like to also thank my good friend, Dr. Karan Garg, who's the senior author on the paper, for being present while we presumably rip his awesome paper to shreds for the next few minutes. So type some questions in the chat. I'll start with, I think Dr. Ryan brings a great question. So we have this benefit. I think there's clearly a selection bias involved in the paper, right? You have 14,000 EVARs, of which 1.8% undergo embolization at the same time. So it's clearly a very select group that was included. And within that very select group, there's benefit. No one would doubt that. But with that benefit being so small, how do you justify presumably extra radiation, extra time, extra money? And how do you select, to combine Dr. DiMuzio's questions with Dr. Ryan, how do you just select which patients actually should have this done? Because there was 1.8% of the folks in the VQI data set that had it done. What was special about those? And Karan, if you want to talk about maybe what lessons you learned about which patients seem to really do well with prophylactic embolization, and what have you employed in your practice?
Thanks, Ravi. Thanks for having me. It's wonderful. Thank you for selecting the paper, and thank you for having. There's a few other authors, Ray Rokosh and Heepal Chang, who helped with writing and analyzing the data. So for me, it's the reason this topic is interesting. I've seen that there's some new literature coming out. I read a paper out of the Leipzig group in Germany, showing their single center experience with this. And, the criteria that they use is like vessels larger than 3 to 4 millimeters are the ones that they've been coiling, and they saw some success with this. And the reason this is interesting to me is that we all struggle with these endo leaks, and these when the sac doesn't regress, and you're like, and you got to go re-intervene on them, and as they get larger, I think it becomes tougher to figure out where the endo leak is really coming from. And to me, the idea of prophylactically embolizing these large vessels is sort of akin to open surgery, which, in a way, you get the most durable result, right? I mean, when you tie off and you sew the vessels on the inside, you ain't coming back for a type 2 endo leak. You might be coming back for many other things, but not a type 2 endo leak. So, while I think this concept and the technology and the technique of this is sort of controversial and a bit new, I think the analysis that we performed shows, and the VQI is by no means perfect. We don't know why these patients had these branch vessels embolized, so we have no idea. But I was a bit surprised, but all we did show was that there was increased sac regression, that the change in the diameter was statistically significant. And when we talk about sac regression, it's like, I know it's becoming like the new sort of cure for aortic aneurysms. And I think anything that can sort of help with sac regression and albeit do it, maybe increase cost, but safe and with minimal morbidity, I think is something that we as practitioners should start sort of thinking about, or at least considering in our practice. So that was sort of my thought and what I learned from this.
Yeah, so follow-up question for you and your partners. Since you got this data, have you changed your thresholds for pre-EVAR embolization?
I actually have. So I have started paying closer attention to these naggy lumbars that I particularly see sort of at the base of the aortic aneurysms, like right at the iliac bifurcation. There's always that naggy lumbar that I've noticed a lot in type 2 endo leaks, and I've sort of increased my practice of selectively embolizing some of these. And sometimes it's really hard, and sometimes you don't succeed. But I think with the new the directional catheters and such, I think it's become a bit easier. But I have started routinely embolizing some branch vessels in select cases, yes.
And if I understand correctly, in the data set, the VQI data set, that embolization was done at the time of EVAR. Are you doing that, or are you doing the embolization and then bringing them back a couple weeks later for their definitive procedure?
At the time of EVAR.
Got it. I'd love to hear from others as well. I know there's questions in the chat, but a lot of them have to do with what people are doing. Is there anyone on the call who routinely embolizes even medium-sized vessels to prevent eventual endo leak? Is anyone using this in an aggressive manner more than what we've already talked about? Don't be shy. Feel free to turn off mute.
I'm not. I've asked this question to so many different people. The first time I heard about it was probably 6 years ago when there's a high volume aortic surgeon in Florida doing it. And I've asked Dr. Schanzer, I've asked Dr. Beck, and the general consensus is not really is the answer. No one's doing it yet. And yeah, I don't feel the data is strong enough yet for it. I think Gail Tang is a great response in the chat too about sort of characteristics too. Is the other thing we brought up at VAM this year is when you look at all the papers, there's not really a definitive paper, great evidence that breaks down, what are the vessels that are going to be risks for type 2 endo leak. There have been a lot of groups that have actually looked at this, and I think that's still up for debate even too.
I think the other interesting thing here is, are there lessons we can learn from NELIX, right? Is there a difference between targeted vessel embolization, outflow embolization versus sac filling technology? Because they are sort of different, right? Targeting an IMA or an accessory renal with pre-EVAR embolization is very different than throwing a bunch of trash and other thrombotic agents in the residual sac. And I feel like sometimes we confabulate the two. We talk about them as if they're equivalent, but they probably are not. a lot of series of questions. Do we think that prophylactic embolization would generate different results in small versus large aneurysms? Does the size of the sac matter when thinking about whether to do branch vessel embolization? By Dr. Gomez, it looks like. Karan, what do you think? Does size matter?
You know, that's the question for the ages. You know, I think the challenge with when you go back and see who gets type 2 endoleaks, you know, like the perfect EVAR candidate, you do this perfect EVAR, and then you get this nagging endoleak and growing sac, and it's always like, oh my God, what did I do? What should I have done different? So I don't know if the aneurysm size matters. I think it does make it tougher to embolize the branch vessels, at least what I've experienced. But I think more than size, I think we have to start identifying the factors, like what is it about certain branch vessels that keeps them going? I know people have looked at mural thrombus. You know, what is it? Is it the material of the endograft that makes a difference? Is it, you know, certain endografts, or is it the location, is the size of the aneurysm at the size at the location of the outflow vessel? So I do think there's multiple factors that play into this, but I think to figure out ultimately who's going to benefit from prophylactic sac embolization, I agree with everyone's comments that I don't think you should just walk away from here and start embolizing everyone's outflow vessels and start radiating yourself so like 2 or 3 rays every, you know, simple, straightforward EVAR. But I do think this at least raises a question as to what patients ultimately would benefit from this sort of, you know, approach, because clearly, you know, this is very uncommonly done in the you know, VQI. It's only 1 or 1.5% of patients, but you can make the numbers lie that there was a greater incidence of, you know, change in diameter in the embolization group than not.
As we start moving towards the second paper, I'm going to ask everyone who read this paper who now is more likely to embolize an outflow vessel. Can you use the raise hand function?
Prophylactically, you mean?
Prophylactically. Oh, do we have ability to raise hands? Yeah, we do. More likely. I'm not saying you're going to do it for everybody, but did anyone change their threshold of embolization, prophylactic embolization, based on this paper? Am I the only one?
Maybe you and Dr. Garg.
And great minds think alike, right?
Well, I'm actually changing my opinion now.
Now you're going to put your hand down.
I know I will. I actually think it's worthwhile. I consider it more than I probably would have before reading the paper. I would not have expected that much of a significant impact, is what I would say. Paul, Misty, do we need to move on to the next one?
Absolutely. Thank you, Dr. Rajani and Dr. Garg for really fielding a discussion. There's a lot of chat or a lot of comments in the chat. If there's a specific question that you had that wasn't answered, you can message Dr. Garg and he can respond to you directly. So we are going to move on to the next paper that will be presented by the team from Oregon Health Science Center. And this is failure to preserve the internal iliac artery during abdominal aortic aneurysm repair is associated with increased mortality and ischemic complications, or with mortality and ischemic complications. Dr. Politano?
Helped if I unmute first. Thank you so much for the introduction, and thank you. We're very excited to be here and being able to participate in this journal club. I did have a few quick thank yous to the hosts, the current and exiting enders of the JVS, the colleagues from Rochester with whom we get to share tonight's small screen, our discussants, and the authors of the paper that we'll be discussing. In just a moment, Dr. Al-Ghamdi will discuss tonight's paper, which was the JVS Editor's Choice article for July, and which provides a fair bit of insight into internal iliac artery treatment during aneurysm repair. I'd like to take just a moment to present some background, and for the learners in the audience, just to remind that an aneurysm is considered a blood vessel with a diameter 1.5 times the normal diameter of that vessel. And the prevalence of aneurysms, especially infrarenal aneurysms, is estimated to be about 1.4% for adults between 50 and 84. So that's about 1.1 million people in our country. In addition to that, the incidence of common iliac artery aneurysms in patients with infrarenal aortic aneurysms ranges between 20 to 40%. And so concurrent iliac artery aneurysms can complicate the approach for either open or endovascular aortic aneurysm repair, which could lead to needing a more distal anastomosis site or a more distal landing zone for repair. While coverage or embolization of one or both of the hypogastric arteries can be done without consequence in a lot of patients, this can cause symptoms in up to 26% of patients, including buttock claudication, thigh claudication, sexual dysfunction, buttocks necrosis, colon ischemia, and even spinal cord ischemia, and more. And so there are a couple of nice review papers that have looked at these complications. In a review by Badaki et al., buttocks claudication was more common with bilateral hypogastric occlusion, nearly 1.5 times as frequent as with unilateral occlusion. Colonic ischemia was seen in almost 10% of patients, and spinal cord ischemia can be seen in up to 5% of patients. So while there are lots of people who can get away with this, there are some very serious consequences to hypogastric artery embolization. And there is actually an additive or an increased effect when you occlude both hypogastric arteries compared to a unilateral hypogastric. And so again, for some review of the perfusion from the hypogastric artery, the internal iliac artery has anterior and posterior divisions. The anterior division has 8 branches, 3 of which are the middle, rectal, inferior gluteal, and internal pudendal, which provide important collaterals to the buttocks, the colon and rectum, and the perineum. And then the posterior division has 3 main branches, the iliolumbar, lateral sacral, and superior gluteal arteries, which again provide perfusion to the cauda equina and the posterior. So these are important vessels, and sacrificing them is not without risk. Several options exist for how we can now approach or treat the iliac artery ectasia or aneurysms while performing aortic aneurysm repair. Open operations have options of bypassing to a more distal portion of the normal common iliac artery, separate bypasses or jump grafts to the internal iliac artery, or internal iliac artery ligation. Additionally, depending on the anatomy, retrograde iliac perfusion may be possible to preserve through an aortobifemoral bypass, allowing external to internal iliac artery flow. Endovascular options also include coil embolization of the internal iliac artery in order to treat this. There have been several devices that have been made to accommodate larger common iliac artery diameters, including distal iliac artery limbs that are 24 to 28 millimeters in diameter, available commercially, as well as snorkel procedures or specific iliac branch devices designed to preserve the hypogastric artery flow while maintaining a seal for the abdominal or aortic aneurysm being treated. The Society for Vascular Surgery's guidelines from 2018 for the treatment of patients with abdominal aortic aneurysm address this to some degree, which is to say that the recommendations, which are all 1A strong and high quality evidence recommendations, to preserve flow to at least one internal iliac artery using branch grafts in patients with suitable anatomy. Somehow I have that one duplicated, my apologies. And then staging bilateral internal iliac artery occlusion by 1 to 2 weeks if that's required for EVAR, which is a wonderful concept, but not always clinically possible. Even for open surgical repair, the recommendation is to preserve blood flow to at least one hypogastric artery. And so tonight we're going to address this paper, and I'll let Dr. Al-Gamadi give us the details, but I think this really does add to the data and the implications of hypogastric artery embolization. Hatan, thank you.
Hi, everyone. Can you guys hear me?
We can.
Okay, I'm going to start sharing my screen. Thank you for having me here. My name is Hatan Al-Gamdi. I'm one of the vascular surgery fellows at Oregon Health and Science University. And thank you again for this opportunity. Let's share my screen. So I'm presenting this article today, the failure to preserve the internal iliac artery during abdominal aortic aneurysm repair, which is associated with mortality and ischemic complication. This is coming from our colleague at the Division of Thoracic and Vascular Surgery from Busan National University School of Medicine in Korea. So the study objective, this study investigated the effect of internal iliac artery exclusion or preservation on ischemic complication and overall mortality. In regards to the methodology of this paper, this is a single institution retrospective study in a 10-year period started from January 2010 until December 2019, which involved 326 patients who had undergone elective surgical or endovascular repair of a non-ruptured AAA. And there was patients who were excluded from the study because they lost to follow-up or they had a delayed hypoembolization due to a type 2 endoleak during an EVAR. So the patient, they were subdivided into the EVAR and the open repair group. And then the EVAR, they were divided by the type of internal iliac artery management, either embolization of a single hypogastric or both of them, and stenting up to the common iliac artery. And then the open repair group, again, they were divided again for the preservation of both internal iliac or ligation of single one. And then the outcome that was studied in this paper was the ischemic complications and overall mortality. The patients, they were divided into two groups, as I mentioned before, the bilateral hypopreservation. About 57% of patients had bilateral hypopreservation. 82 of them were in the EVAR group, and 105 or 26% of patients had in the open repair group. And then a single hypo was preserved in about 26% total of the 326 patients. 15% were in the EVAR group and 35% were in the open group. This table here shows the study demographics. So of the 326 patients, 80% of them were men or males with a median age of more than 78. And then in regards to the preoperative hypo internal iliac artery condition, 90% of them had patent bilateral hypogastrics, and only 7% had a single patent hypogastric artery. And in this table, it's showing the incidence of mortality, which is about 15%, as showing here in the last part of this table. So moving on to the study results, the difference in the comorbidities in these patients were stratified by the hypogastric management or the internal iliac artery. There was no significant difference noted in all the variables as shown in this, as this table, but except that the PAD, patient with PAD had a greater, patient with PAD those had like one or more internal iliac artery sacrificed than no internal iliac artery preserved. In regards to the ischemic complications, a total of 50% of patients had ischemic complications, with 47 of patients had failure to preserve the bilateral internal iliac arteries, and 10 of them had 10 of these patients had bilateral internal iliac artery preserved, and 47% had failure of bilateral hypopreservation. And there was a significant difference in the ischemic complications in both groups. Majority of these patients, or the baroque claudication was the most common complication. As we can see here, 29% of the patients had baroque claudications in the failure to preserve both hypos, and only 4% had baroque claudication in the success of preservation of both hypogastrics group. And as we can see here, only 3 or 5.7% of patients had ischemic colitis in the no preservation group. Moving on in the study results, this table showed the risk factors after multivariate analysis for ischemic complications and overall mortality. So there was significant difference showing like the failure of bilateral hypopreservation, management of the internal iliac artery, and hyperlipidemia was significantly affected or increased the incidence of ischemic complications in these patients. And then in regards to the overall mortality, patients with stage 5 CKD and age more than 75% and failure of both hypopreservation was associated with increased mortality in these patients. This is a Kaplan-Meier curve, again, showing the risk factor associated with ischemic complications. And as we can see here in this figure, that patients with no hypopreservation or failure of bilateral hypopreservations have increased risk of ischemic complications. And then in regards to the overall mortality, patients with stage 5 CKD, failure of bilateral hypopreservation had increased risk of overall mortality in this group of patients in this article. There was some few limitation in this article. First of all, it was a single center study which introduced selection bias. As we know that the embolization method has been reported as a significant factor in ischemic complications in other studies, but this study did not describe the embolization method for the hypogastric in this article. And then the cause of mortality could not be evaluated, and there was no comparison between the hypogastric preservation and the exclusion groups. And then, as we all know, that the IMA ligation is a known risk factor for ischemic colitis, regardless of the status of the hypopreservation, and this was not mentioned in this article. Erectile dysfunction was not included, which is a known risk factor again of failure to preserve hypogastric. This was not included due to lack of data in this paper. And then a couple of more limitations that we think that they treated all retrograde perfused hypogastrics as it was sacrificed. So we were suggesting that maybe a subgroup analysis of ligated or plugged hypogastrics versus retrograde perfusion to determine if that makes a difference in this population. And also, there was no place to discuss the proximal zone of treatment, either in the EVAR or the open groups. They didn't include like in the infrarenal endograft or the infrarenal clamp zones, which could make a difference in spinal cord perfusion. Finally, in regards to the conclusion of the study, I'm sorry, I'm having connection here. So unilateral hypoexclusion is safe and frequently implemented during AAA repair of bilateral hypopreservation can lead to more ischemic complications, increased long-term mortality. And with that, I open the discussion for this article. Thank you for having me here again.
Thank you. Dr. Gail Tang is going to help us moderate this paper, and there's a lot of good discussion in the chat, so please add your comments. It will be challenging. Dr. Lee was not able to join us. He just started an emergency case, so we'll have to rely on Dr. Agamadi and Dr. Politano to maybe help us a little bit.
So I think one thing that was a little disturbing was that they did not actually differentiate between the groups that started with occlusions versus the ones that were ligated intraoperatively. And I think that analysis might have been interesting. I do wonder about, is 2 weeks really enough to fully collateralize, or would a longer period of time, like 4 to 6 weeks, be better before proceeding with operation of or AAA repair?
Dr. Tang, I had the same thoughts for this paper exactly. One of my concerns was that I think this was nicely done, but I would have loved to see more subgroup analysis, and that's exactly one question I have. Is really, it would have been nice to see people who started with 2 patent hypogastrics and see what happened in terms of their ischemic complications. And it may just have been that they didn't have enough numbers, even though they had over 300 patients. That might not have lent itself to as much subgroup analysis. They did mention that I think at 6 patients, their open repair was actually done to reinstitute flow to a hypogastric that was occluded only at the origin. So there was a little bit of crossover for the paper as well. I would have also liked to see subgroup analyses, like Dr. Al-Ghamdi mentioned, for where we did our proximal clamp or anastomosis. I entered this paper assuming infrarenal, but it was never confirmed anywhere. And I'm curious about clamp location as well, and those would have been interesting.
Yeah, I think the small numbers problem is when you have a relatively infrequent complication like this ischemic colitis. I think that may be why it wasn't significant. They just didn't have enough cases, because you would expect that with bilateral hypoligation, and they do state in the manuscript that all the IMAs were ligated, none of them were reimplanted. So that you would have seen, and they're like 0.5 versus 3%. Well, that not statistically different, but probably not enough numbers to, so I think that's probably a type 2 error of inadequate sample size. So there was an interesting question in the chat, which now I've managed to have it disappear, from Dr. Ryan about, there was a recent JVS article mentioning that when IBE was used, that the sac size did not decrease as much as when the internal was embolized or excluded. Any comments, because this article would suggest everybody should get IBE and as much internal iliac preservation as possible, but is that going to result in less sac regression and worse aneurysm outcomes?
I think that's a hard thing to kind of predict right now. I think you see a lot, especially as we're looking through the chat and you're seeing a lot of people commenting on various different parts of that. I'm not sure that Dr. Politano might be willing to address it, but luckily she sent her link to all of her partners. So all of her partners are named Dr. Politano. And I do see Cherry is on here, even though he's listed as Dr. Politano. He might be willing to address that thought if you'd like. Terry, do you want to unmute and maybe some comments?
Sorry, Misty. I'm just in the middle of a call, listening to a transfer center dialogue. I'll be with you in about 4 minutes.
Okay, I understand. Of course, right when we had a question. So.
Well, the other thing is they just did publish the 5-year results in JVS for the IBE trial. And in that trial, they actually, if you had bilateral common iliac aneurysms, you had to exclude one of them. You were not allowed to do bilateral IBE in that trial. So all those patients got unilateral IBE. But I guess the question for the audience is, you know, do you routinely do as the trial and just sacrifice one, or do you go for bilateral IBE? Now we're starting to talk like 9, 10 devices for these patients, longer fluoro times, everything like that.
And also that can be really difficult. You know, you have to do alternative access sometimes when you're doing these. And I think it really does add to the complexity.
Sorry, can you hear me now?
We can.
So I guess the issue with the bilateral IB, I haven't found it to be necessitating alternative access most of the time, unless you have a really short renal to aortic bifurcation distance. I think you can get in on both sides through the femoral artery. And with respect to, I mean, yeah, sure, it's costly. But I usually routinely will do bilateral IBEs if it's, you know, anatomically appropriate, and it's to preserve both. And in the event that we lose one of those internals, we know the other one's patent with the contralateral IBE.
Gail, Ben Pierce it had an interesting kind of comment in here. Then do you also have a manuscript you're just kind of pointing out? Do you want to unmute and talk a little bit about what you suggested? You have a couple of other people commenting on it in here too.
Yeah, this is for open repair.
For open, well, yeah. So I would echo what Sherry just said. When we do endo, I'll try to do both bilateral IBE. Again, within the anatomic constraints, and somebody I think in the last chat did make a good point that we're talking about all this anatomic stuff. If it's an 86-year-old person and you're just trying to keep them from rupturing at home, I think it's probably best to do the most straightforward thing. In that case, I might just do one and then coil the other. But in general, I do believe in preserving both, because I think your long-term risk of limb occlusions on the side that you coil, I think when they remodel with extension of the external, they get more complications with limb occlusions and with type 3 endo leaks as well. So I think it's best to do bilateral and endo in a younger, healthier right patient. The open thing is we're writing it up. I'm a research resident who's presenting next month. You guys are going to love him. He's not to dog anybody else. He's the most conscientious vascular resident in the country. He's going to write a really great manuscript. But we've done a whole handful of these now where patients who are young, like in their 50s, most of them are either bilateral common iliac artery aneurysms and even the origin of hypogastric aneurysms. Rather than dig down in the pelvis, we'll go down and the day before and go up and over with sheaths from both groins and put regular viabonds down to the first division, or sometimes we'll coil the posterior division and land the viabond in the anterior, bring it up near the aortic bifurcation. And then the next day we come back and do a standard. I like to do transperitoneal. Adam's done a couple of them, retroperitoneal, same technique. And then you just open the aneurysm sac after you put your proximal clamp on, and you put a balloon occlusion catheter in those little viabonds. And then we've pre-make a Gumby, that's what we call it here in Alabama, and just sew the limbs right to the viabonds. The key is not putting a clamp on them so that when the med student inadvertently touches the clamp and moves it, it doesn't pull it out of the pelvis. We learned that lesson the hard way on one. But it's a really neat way to preserve both hypogastrics and not have to dissect out all the, deep in the pelvis, knock yourself in all that trouble. So like I said, I actually presented the first couple at VEITH, the last one before COVID. And then we've accumulated enough to write a manuscript. So hopefully that'll be submitted, I think, within the month. But I'm happy to share the slides with anybody if you email me.
So what do people think about patients with spinal cord injury in AAA? Because, the major complication, buttock claudication, is not really an issue for them. Is it worth it to try to avoid late type 3 or is it just go ahead, sacrifice it?
I think a lot of people would really consider to preserve those.
Yeah, my take on it is most patients with buttock claudication get better after 6 to 12 months. And the ones that don't just haunt you for each of their subsequent follow-up. and you wish you had done everything you could to do it. And those are the ones we remember. We don't remember the ones that get better. And so I think that's why I'm more aggressive.
Yeah, but the spinal cord injury patient's never going to come back and complain of buttock claudication, right? They're not walking. So another question here is, you know, some of these internals presumably are heavily diseased, right? Especially the open ones that you sacrifice, you know, it's a calcified rock, and maybe it was at a super high grade stenosis at the origin. Is some of this mortality signal more that really that they have more atherosclerotic burden and less that you sacrifice their hypo?
I would think in those cases, you might not see some of these complications, and those might be the patients that you get away with it because they may not have had, or they may have had alternative pathways to begin with.
Yeah, but you see that late mortality signal, right? More of them died.
It would be nice to see the authors of this take that question into their data, because I think they might be able to answer it. They did have data on who had PAD per group, and they had data on the hypogastric status prior to surgery. So it may be something that they can get either out of this data or by expanding their data set and continuing to accrue more patients.
Yeah, I think Dr. Lee left his email address in the, I'm sorry, I have an emergency surgery, so we might have to email him back to say, hey, this question came up. We're really interested in the answer.
Absolutely. I think, again, it's hard, unfortunately, when some of the authors aren't here, because there is a lot of discussion generated about this. You know, every year at the vascular annual meeting, there's one or two presentations on it. So I think we've really tried to cover everything here. I want to thank everybody, for Dr. Tang especially, for moderating this section. It's really hard when the authors have to pop off, and we need everybody from the audience to participate, or the multiple Dr. Politanos that have joined us today to participate. And I think for that, though, we'll kind of close this session down. Thank you, everybody, for being here for the August version of the JVS Journal Club. Or sorry, it's July. It's still July. But we will, August is coming. It'll be here in a couple of weeks. So you'll see it advertised on SVS Connect. You'll see it advertised on Twitter, and we will have 2 more interesting editorials or editor's choice articles coming up in the next month for us to discuss. And that will be again with the University of Alabama and Stony Brook joining us as hosts.
Thanks for being here from France, Misty. Take care, everyone.
Good night.
Good night.